Hello and welcome to MK's Medical Review Series. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at heart failure. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon as well to be receiving notifications every time I post. Drop a comment, drop a like, share the link to the page to help the page reach 2,000 subscribers before June next year. My name is Dr. Moses Kazevu. Grab your piece of paper, grab your pen, and let's go. So before we actually go into heart failure, there are some important physiological terms that I want us to define. I know I defined these things when we're talking about hypertension. I will define them again when we are talking about heart failure because they are very, very important for you to know, because this is going to segue into us understanding the pathophysiology of heart failure, understanding the management modalities that are present with heart failure. So we're going to talk about blood pressure, we're going to talk about cardiac output, we're going to talk about heart rate, stroke volume, afterload, preload, total peripheral resistance, venous return, the Frank-Starling phenomenon, and we're also going to talk about the control of blood pressure in so much detail. So beginning with blood pressure, remember that this is a function of the heart and the blood vessels consisting of two values. It's going to be consisting of a systolic value, which is a measure of how well the heart is functioning, how well the heart is contracting. So if there is a problem with the contractility of the heart and it's failing to contract, then you refer to that as systolic failure. And then on the other hand, diastole is pretty much the elasticity of the blood vessels and the filling of the heart. So if the heart is not filling up with blood, remember that the heart fills up with blood when it's in diastole. When it is relaxed, then this person's heart will not be receiving enough blood. If the heart is not receiving enough blood, it cannot pump out as much blood. So this person will be in what is referred to as diastolic failure. So alternatively, blood pressure can be defined as a function of cardiac output times total peripheral resistance, where cardiac output is going to be equal to the stroke volume multiplied by the heart rate. So in essence, blood pressure is equal to the stroke volume times the heart rate times the total peripheral resistance. Now you ask me, what is the cardiac output? Remember that cardiac output is going to be equal to the heart rate times the stroke volume. So cardiac output is pretty much the amount of blood pumped out from each ventricle within a minute. So the total amount of blood that's pumped out from each ventricle within a minute. So from the left ventricle and from the right ventricle, you have 5 liters per minute of blood being pumped out as your normal cardiac output. Then, of course, your heart rate is the number of times your heart beats. Normal heart rate is between 60 to 100 beats per minute. If someone goes below 60 beats per minute, you refer to that as bradycardia. If someone goes above 100 beats, you refer to that as tachycardia. Then, of course, the stroke volume is the amount of blood that is pushed out of the heart, or that is pumped out of the heart with each contraction. Okay, so that's the amount of blood that is pumped out of the heart, the total amount of blood that is pumped out of the heart with each contraction, with each systole. You call that as your stroke volume. Then I'll explain preload before I actually explain afterload. So preload is just simply the amount of blood that is present within the heart before it contracts. So you can think of the preload as your end diastolic volume. So if by normal means, remember that you have 2 phases of contraction and relaxation, 2 phases in the cardiac cycle predominantly. You have what is known as a phase of systole, where the heart contracts and pushes out blood. Then you have another phase of diastole, where the heart relaxes and fills up with blood. So these 2 phases alternate to make the heart beat. So if you fill the heart with blood, the amount of blood that is going to be there at the end of diastole is known as the preload. So it means that if you fill your heart with more blood, then the preload is going to be higher. That means that the end diastolic volume is going to be higher. And that means even that the strain that you're putting on the heart is going to be higher. What are the ways in which the end diastolic volume can actually be increased? If you constrict the vessels, if the veins actually, to be specific, contract, it means that they're going to be pushing blood back to the heart. We remember that veins have a special type of mechanism to allow unidirectional flow of blood. One way in which blood returns back to the heart in the venous system is because they exist in between muscles. So as the skeletal muscles are contracting, they push the blood back towards the heart. The second mechanism is that you have valves inside the veins that ensure unidirectional flow of blood towards the heart. And then, of course, there's a negative pressure system that is present in the chest. Whenever you inspire, the intrathoracic pressure reduces. And this intrathoracic pressure means that it's going to cause blood to flow into the thoracic cavity. So the venous return is going to increase. So preload is largely dependent on the venous return. Then on the other hand, afterload is now simply the amount of work that the heart has to put in to overcome the resistance to the flow of blood. So in essence, the afterload is similar to what we refer to as the total peripheral resistance. So each blood vessel, the arterioles and the arteries, offer a resistance to the flow of blood. Think of it like this. You're in a room and you have 100 people in a room, and they all have to leave through one door. So if the door is small, there's going to be a lot of pressure across the small door. If the door is large enough, there's not so much pressure and everyone can easily leave. Same thing with the blood vessels. If the blood vessels are constricted, the arteries, the total peripheral resistance is much higher. So it means that the heart has to contract harder to overcome this resistance. If the diameter of these resistance vessels is increased, it means that the heart has to contract less. Okay, so keep these concepts in mind. So it's the same discussion as total peripheral resistance. So if we go back to blood pressure, remember that blood pressure is going to be a product of cardiac output times total peripheral resistance. So it means if the cardiac output increases, the blood pressure increases. If the total peripheral resistance increases, the blood pressure increases. And remember that cardiac output is a product of heart rate multiplied by the stroke volume. So if the heart rate increases, the cardiac output will increase and the blood pressure will increase. If the stroke volume increases, the cardiac output will increase and the blood pressure will increase. It's like directly proportional. Then I've already explained the concept of venous return, which is pretty much the blood that is returning back to the chambers of the heart. Then when you talk about the Frank-Starling phenomenon, I like to give an example just like I gave an example when we were discussing this in hypertension. So picture this. Picture you and I are working in a department. Let's say we are examining students, 300 medical students, and we give them, let's say, an internal medicine test. And let's say we administer the test on a Wednesday, and the Senate actually needs the results by Monday. So suppose we administer the test on the Wednesday and it's successful, and I give you, let's say, 20 scripts to mark. And I say, mark these 20 scripts and by Friday you should be done. It's okay, you're going to be marking at a certain pace. Now, suppose on the same Wednesday, I come and give you 20 scripts, 20 more scripts. Now you have a total of 70 scripts. You can still manage to make the deadline, but now there's more work for you to actually complete. So it means that you're going to be working at a much faster rate. You're going to be working much harder. Suppose now, maybe on the same Wednesday, I come and get 50 scripts away from you, so you just remain with 20. You won't be working at a lightning speed. You will reduce your speed and you will reduce the amount of work that you're putting in so that you can actually match the deadline so you don't really stress yourself. Now, suppose it gets to a Thursday and actually I come with 100 scripts and say, mark these and I need them by tomorrow. You feel overwhelmed and you feel that this is beyond your capacity for you to actually manage to mark all the scripts given the short space of time. So the same thing is happening with the heart. So the contractility of the heart within physiological limits, the contractility of the heart is dependent on the stress or the distension, the stretching out of the myocardial cells. So the more the myocardial cells are stressed apart, then the greater the contractility. That's within physiological limit, in a way that the venous return is supposed to match the cardiac output. So if the venous return increases, the cardiac output is also supposed to increase. If the venous return reduces, the cardiac output is also supposed to reduce. Then there's a way in which blood pressure is going to be controlled. So I will not talk about it on this particular slide. I will talk about it when we actually talk about the pathophysiology of heart failure. But for now, I also want to introduce other concepts. So I want you to know the ejection fraction. Now, ejection fraction is just simply a ratio of the stroke volume over the end diastolic volume. Recall that the stroke volume, the normal stroke volume, with each contraction, you push out roughly about 70 mils of blood. So with each contraction, there is about 70 mils of blood that is pushed out. Then the end diastolic volume is about 140 mils of blood. So it means at the end of diastole, you should have roughly around 140 mils within the ventricles. So it means that your ejection fraction will be your stroke volume, which is 70, divided by your end diastolic volume, which is 140, multiply that by 100. So your normal ejection fraction should be at least 50%. Okay, so there is some gray line before you actually deem that the person has actually gone into heart failure. So the gray line is between 40 to 49. So if someone is there, this is what is known as a gray area. They do not necessarily have heart failure per se, but usually if they have heart failure where the ejection fraction is impaired, we usually use a benchmark of 40%. So they should have an ejection fraction that is less than 40%. I really do hope that these principles and these physiological terms have made sense to you, because if they haven't, then it will make explaining the pathophysiology of heart failure very, very hard for you actually to know. So let's move on and see what the topic is all about. So remember that heart failure is actually a syndrome. It's not a disease. It's not a complete diagnosis on its own. So heart failure is actually a complex clinical syndrome that is going to be caused by either structural or functional abnormalities in the cardiac muscle. And these functional or structural abnormalities are going to be leading to impairment in the ability of the heart to function as a pump. And so this impairment means that the heart is no longer going to be able to pump blood out to meet the metabolic demands of the body. So like I already said, heart failure in itself is a syndrome and it's not a complete diagnosis in itself. It's important to always find an underlying cardiac abnormality when you have heart failure. It should always be secondary to something. You can think of heart failure as kind of like end stage disease for the heart, because almost all the cardiovascular conditions will almost invariably lead to heart failure. And the incidence actually increases with age, and heart failure affects about 1 to 3% of the general population. 10% are actually elderly patients. And I hear the term congestive heart failure being actually thrown around multiple times. Sometimes it may be thrown around in a wrong manner. So when you're talking about congestive heart failure, you're just talking about a patient that's going to be typically having heart failure and features of fluid overload, especially pulmonary edema. I will talk about what are the features that you're going to be expecting to find on the examination with pulmonary edema a few slides later on. And of course, the prognosis is quite poor for heart failure patients. It's around 25 to 50% of the patients that will die within 5 years of the diagnosis. So what are some of the causes of heart failure? So the three most important causes in our setting. Number one, most important causes, of course, ischemic heart disease. That's your acute coronary syndromes, your myocardial infarctions, your unstable anginas, your vasospastic anginas. Then your next cause is, of course, cardiomyopathies, most likely the dilated cardiomyopathies. Remember that there are types of cardiomyopathies. There are restrictive cardiomyopathies, dilated cardiomyopathies, and hypertrophic cardiomyopathies. The dilated cardiomyopathies are very common cause of heart failure. Then hypertensive heart disease is also quite common, because hypertension is known as a silent killer, so you may not even know that you are hypertensive. And other causes include hypertrophic and restrictive cardiomyopathies, valvular heart lesions like mitral, aortic, or tricuspid valvular lesions. You have congenital heart disease like atrial septal defects, ventricular septal defects, alcohol and drugs such as doxorubicin, which have the ability to actually cause a dilated cardiomyopathy. You have hyperdynamic states such as anemia, thyrotoxicosis, hemochromatosis, Paget's disease, which results in a type of heart failure that's known as high output failure. You also have right ventricular failure, which is often due to a right ventricular infarct, pulmonary hypertension, pulmonary embolism, as well as a chronic obstructive pulmonary disease or disorders. You also have tricuspid incompetence, which falls under valvular lesions, pericardial disease such as constrictive pericarditis, and pericardial effusion. So you should be able to know at least a significant number of causes of heart failure. And remember that these are also topics on their own. So they will have clinical features that are unique to these conditions that will help you pick up the diagnosis when you're meeting your patients on the wards, when you're meeting your patients in clinic. So how exactly are we going to be classifying heart failure? You can classify it anatomically, functionally, and according to the duration. If you so wish, you could even actually classify it etiologically. So anatomically, remember that the heart is divided into two chambers, or rather 4 chambers and 2 sides. You have the atria, the right and the left atrium. You have the ventricles, the right and the left ventricles. So let me just imagine this. You're a red blood cell, right? And you find yourself in the right atrium, okay? So from the right atrium, you're going to be moving to the right ventricle, past the tricuspid valve. Then from the right ventricle, you're going to be pumped out past the pulmonic valve into the pulmonary trunk, which divides into the right and the left pulmonary arteries that are eventually going to go to the lungs for the purpose of oxygenation. This is known as the pulmonary circuit. Now, oxygenated blood that is coming from the lungs is going to be draining back into the left atrium via the pulmonary veins. Remember that pulmonary veins are going to be carrying oxygenated blood. Generally, veins carry deoxygenated blood, but pulmonary veins carry oxygenated blood. Same thing with arteries. They generally carry oxygenated blood, but the pulmonary artery is going to be carrying deoxygenated blood. So you're now a red blood cell and you're coming from the lungs. You have now gotten your oxygen. You're now going to find yourself into the left atrium, okay? Then from the left atrium, you're going to go past the mitral valve. You're going to go into the left ventricle. And remember that the left ventricle has the greatest muscle mass of the entire heart. Then from the left ventricle, you're going to be pumped out through the aortic valve into the aorta. Then the aorta is going to be distributing the blood to the head and the rest of the body. And then this blood is going to be finding its way via the inferior vena cava as well as the superior vena cava back into the right atrium. So this system, which is going to be affecting or the system that's going to be taking blood to the head and the body, you call that as the systemic circulation. So when you talk about heart failure, the right side of the heart can fail and the left side of the heart can fail. Remember that the right side of the heart is going to be pumping blood to the lungs. And where is this blood coming from? This blood is coming from the systemic circuit. So it means that if the right side has failed, think of it like this. If you're on a road and you're going to town and you realize that there's a blockage in the only route or the only road leading to town and it's blocked, you go back home. So if this blood is now congested on the right side because the right heart cannot really pump this blood going to the lungs, so it means that it's going to backflow back into the systemic circuit. So if it backflows back into the systemic circuit, now you're going to be increasing the hydrostatic pressure across the vessels in the systemic circuit, and there's going to be a lot of transudation of fluid. So there's going to be a lot of peripheral edema. Now, on the other hand, the left side of the heart is going to be pumping to the head and the body, and it's receiving blood from the lungs. So if the forward pathway is blocked, so it means that blood is going to backflow into the lungs, increase the congestion in the lungs, increase the transudation, and this is going to lead to manifestations in the pulmonary circuit, which is why I say right-sided heart failure is going to lead to manifestations in the systemic circuit, where you're going to be seeing things like peripheral edema up to the thighs, the sacrum, even sometimes the abdominal wall. You may have ascites, you may have nausea, anorexia, facial engorgement, you may have pulsations of the neck, and you may have even this affecting the face. You may have features of tricuspid regurgitation. You may even have nose bleeding, epistaxis. So remember that they can actually play around with your mind on the MCQs and say heart failure can actually cause nose bleeding. It's actually true, right-sided heart failure. Then with left-sided heart failure, the problem is with the left side of the heart that has failed. So it means the manifestations are going to be in the pulmonary circuit. So there's going to be dyspnea, there's going to be poor exercise tolerance, there's going to be fatigue, orthopnea, paroxysmal nocturnal dyspnea, nocturnal cough, which may or may not have a pink frothy sputum. They may be wheezing, which is often referred to as cardiac asthma. It doesn't mean that someone has asthma, but it's because of the congestion that's happening in the lungs that this person will present to you with asthma-like symptoms. Then you may also have cold peripheries, weight loss, and muscle wasting. So some causes of right-sided heart failure include cor pulmonale. Remember that cor pulmonale is right-sided heart failure that is due to a lung pathology. So the primary lung diseases like chronic pulmonary obstructive disorders are going to be causing vasoconstriction of the pulmonary vessels. And this is going to be leading to poorly ventilated lung tissue to correct the decreased ventilation to perfusion ratio. And this is, of course, going to be leading to pulmonary hypertension. And with pulmonary hypertension, it means that the right side of the heart now has to work harder to overcome this resistance. So it means it may end up failing. So you develop right ventricular failure. And then left ventricular failure can also progress into right ventricular failure due to the same pulmonary hypertension overloading of the pulmonary circuit. And so the right heart has to generate much greater force, and then eventually it's going to fail. Then pulmonary stenosis. Pulmonary valve stenosis is an uncommon cause. Then sometimes you may have biventricular heart failure or congestive cardiac failure, where you have features of both systemic manifestations as well as pulmonary manifestations. Now, I want to explain two important things here, especially on the side effects, or rather, these clinical features. I want to explain about orthopnea, and I want to explain about paroxysmal nocturnal dyspnea. So orthopnea is just simply difficulty in breathing when someone lays down flat. So you find out that heart failure patients will often fail to lay down flat. So I'll need to go to show you a blackboard for you actually to understand what I am talking about when I'm talking about paroxysmal nocturnal dyspnea, and also when I'm talking about orthopnea. So I'll show you a blackboard here. So we have a lung over here. Excuse my very wonderful art. So we have a lung over here. Let's say we divide this lung into 3 zones. Okay, we have the upper zone, which I shall call Z1. We have the middle zone, which I shall call Z2, and we have the lower zone here, which I shall call Z3. Okay. Now, remember that there are 2 important concepts that are present for gaseous exchange and for respiration to actually happen. There is a process of what is known as ventilation, which is just simply movement of air in and out of the lung. And then there's a process of perfusion, which is to do with blood vessels reaching the alveoli, gaseous exchange. So perfusion is going to be influencing gaseous exchange. Now, there's what is known as an ideal ventilation to perfusion ratio, where you have almost near equal amount of air versus the amount of blood that is reaching there to carry the air that has been brought in, and also dump out the carbon dioxide that has been brought in by the rest of the body, or that has accumulated from the rest of the body and transported to the lungs for excretion. So here, remember that we generally do not respire with all these 3 zones. We usually just use zone 1 and zone 2, the upper zones of the lungs. So you find out that here in zone 1, you have a lot of air here. So there is a lot of ventilation that's here. But perfusion is not so much. So there is decrease in perfusion, because most of the blood is going to be pulling at the lower aspects of the lung because of gravity. So here you have what is known as wasted ventilation. You have a lot of air, but it's not being carried by blood because not a lot of blood vessels are recruited here. Then on zone 3 here, the bases of the lungs, you have not so much ventilation. Okay, maybe unless if you're an athlete and you actually use even the lower zones of the lungs, but in general, individuals and normal individuals like you and I pretty much doubt that you use all the entire zones of the lungs. So you have pretty much reduced ventilation, but a lot of blood flow. So you have increase in perfusion. So here there is what is known as wasted perfusion. So in the upper zones, there is wasted ventilation. In the lower zones, there is wasted perfusion. Whilst here in zone 2, there is a perfect ratio of the ventilation to perfusion. So because of this, this is what is referred to as a ventilation to perfusion ratio mismatch. Of course, there are some mechanisms that the lung has to put into place to correct this ventilation perfusion mismatch, but I will not go into that because that will be talking about physiology. Now, suppose you have someone that has fluid that is accumulating in these lungs, and remember that fluid has a much higher density than air, so it's pretty much going to be settling down at the bases of the lungs here. So you have this fluid that's settled down at the bases of the lungs. It won't be a problem when this person is seated upright. Why won't this be a problem when this person is seated upright? It's because already zone 1 is clear, all the fluid is in zone 3. You're going to be respiring mostly from zone 1 and zone 2, and the blood is going to be also in some in zone 1 and some of it in zone 2. So it means that this person will respire just quite all right. When they are up and about during the day, respiration will be okay. Now, what happens to this individual when you have this individual now changing positions and actually laying down flat so that they eliminate that effect of gravity causing the fluid to settle to the bases of the lung. So what will happen now is that the fluid will undergo redistribution, and it will now be redistributed across the three zones because this person is now laying down flat. Now, when this fluid is redistributed across the different zones, then this person becomes breathless because now that gaseous exchange interface between the alveoli and the capillaries is affected. So that's what we refer to as orthopnea. Then paroxysmal nocturnal dyspnea. So in individuals that have heart failure, you have the fluid that is trapped in the peripheries of the body, okay? Trapped in the peripheral, the lower limbs, predominantly. Now, when someone goes to sleep, probably 1 to 2 hours just into sleep, most of that fluid is actually taken back into the venous system via the lymphatics. So most of the fluid is actually taken back slowly into the venous system. So there's going to be an increase in the blood that is in the venous, the blood that is in the circulation. So it means that with this increase in blood that's in the circulation, remember this is a heart failure patient already. So it means that you're going to still be putting the heart at a much greater strain. So it means that there is now going to be more exudation, or rather transudation of fluid in the lungs, and this is going to now interfere with that gaseous exchange interface, and this will cause a person to wake up from the sleep feeling breathless. Okay, so if you ask the patients on your history, do you wake up to catch a breath, then you refer to that as paroxysmal nocturnal dyspnea. I really hope that makes sense when I explain these two terms. Now, you may also have dyspnea, which is just simply difficulty in breathing, a poor exercise tolerance, fatigue because of already known reasons. There's a poor gaseous exchange that's happening, and remember that oxygen is needed to create energy. The same reasoning is happening with the nocturnal cough. It's because you have a lot of congestion in the lungs, and because of this congestion that is happening in the lungs, you may have increase in hydrostatic pressure. Remember that there are two forces across a blood vessel. There's a force that tends to push fluid out of the vascular space. You refer to this as your hydrostatic pressure. There is a force that tends to pull fluid into the vascular space. You refer to this as your osmotic pressure. You have a special type of osmotic pressure, which is known as oncotic pressure, which is due to the proteins. So now, because you have increase in hydrostatic pressure, you may force some of the capillaries in the lungs actually to rupture, and actually this is what will give you the pink frothy sputum. Then moving on, you can classify heart failure functionally into two types. What is known as systolic heart failure, or heart failure with reduced ejection fraction, versus heart failure with preserved ejection fraction, what is known as the diastolic failure. So most cardiologists are actually using this type of classification, and that's for, as a student, if you're learning this for the first time, it's easy for you to learn using the anatomical classification, because this will help you now figure out what clinical features you're going to expect. But as you now get comfortable with the topic, you should incorporate other things, and you should now be able to tell us heart failure with reduced ejection fraction, especially the final year students. Heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. So heart failure with reduced ejection fraction, it means that the problem is this with the systolic component of the heart. So remember that the systole is where the heart contracts. So you have inability of the ventricles to contract, and the normally results in a decrease in cardiac output. So remember that your ejection fraction must be greater than 50%, but now in these individuals, you have an ejection fraction that is less than 40%. Remember I told you that there's a gray area. 40 to 49 is a gray area. Then heart failure with preserved ejection fraction is, you can also refer to this as diastolic heart failure, where the ventricles actually fail to relax. Remember the Frank-Starling phenomenon that I told you about? So if the heart is not really filling in with blood, so it means it's not going to be stretching out the muscles, it's not going to be contracting as it's supposed to be, so it means that even the cardiac output is going to reduce. So it means that even the perfusions of the organs are going to reduce. So, but if you check the ejection fraction, it will be near normal. So it will be above 50%. So sometimes you may have actually features of both systolic as well as diastolic failure. Then you may have high output failure, where the cardiac output is actually normal or increased in the face of an increasing needs. For example, in patients with thyrotoxicosis, in patients with pregnancy. And then you may also have low output failure, where the cardiac output is low and it fails to increase normally with exertion. Then like I already told you, heart failure with reduced ejection fraction. The ejection fraction is less than 40%. And of course, the mid-range gray area is between 40 to 49. This is also known as systolic heart failure, or you can refer to this as left ventricular systolic dysfunction. The reason why we're focusing more on the ventricles is because even when the atria fail, 75% of the filling of the ventricles is done passively. It's only that extra 25% that fills the ventricles. So even when the atria fail, it's not so significant. But when the ventricles fail, it becomes significant because virtually all the blood that is being pumped out from the ventricle is done as an active process as opposed to a passive process. So some causes of heart failure with reduced ejection fraction include things like ischemic heart disease or myocardial infarction, which happens to be the commonest cause, hypertensive heart disease, cardiomyopathies, diabetes, which is usually associated with ischemic heart disease, valvular diseases, arrhythmias, even drugs and alcohol. Then, of course, in systolic heart failure, there's going to be a reduced contractility of the heart, like I already told you. So the manifestations are going to include weakness, fatigue, reduced exercise tolerance, and other symptoms of hypoperfusion. When you talk about heart failure with preserved ejection fraction, then here you have the left ventricular relaxation that has failed. So there is inadequate filling, and this is going to decrease the stroke volume, but you're still going to have a normal ejection fraction that's greater than 50%. So this is also known as diastolic heart failure, the commonest cause being hypertension because it also affects the blood vessels. Diabetes also affects the blood vessels. Constrictive pericarditis affects the relaxation of the heart, because remember that you have a pathology that's affecting the pericardium. Remember that the heart is enclosed in a pericardial sac. You may also have a cardiac tamponade, which is blood that's accumulating within the pericardial space and impeding the heart from relaxing as well as contracting. This is a medical emergency. Then, of course, you may also have restrictive cardiomyopathies. So heart failure with preserved ejection fraction is much more common in women than in men, especially in elderly women with hypertension. So here's a table just to compare the two, systolic dysfunction versus diastolic dysfunction. Here you have hypertension, ischemic heart disease, idiopathic cardiomyopathies, which may be associated with HIV, dilated cardiomyopathies, valvular diseases, alcoholic cardiomyopathy, drug-associated cardiomyopathies, myocarditis. Then you may also have diastolic dysfunction, which may be due to abnormal filling that may result in hypertension, fibrosis, ischemia, angina, constrictive pericarditis, that is very common in TB, restrictive pericarditis, and as well as hypertrophic cardiomyopathies. Then when we talk about high output heart failure, this is actually quite rare, but the output of the heart is normal, and it may also even be increased, but there is also an increase in the needs of the body. The metabolic demands of the body have also increased. So there are some conditions that may actually increase the demands of the body, such that the heart, despite it increasing its cardiac output, it may not still meet the demands of the body. So conditions like anemia, conditions like pregnancy, conditions like hyperthyroidism, conditions like Paget's disease, atriovenous malformations, beriberi, and often initially, you're going to get features of right-sided ventricular failure, but later on, left ventricular failure can become evident. Then low output failure, the cardiac output is low and it fails to increase normally with exertion. So you may have a problem with the pump. It may be systolic failure or diastolic failure. You may have some drugs that decrease the rate, like for example, beta blockers, or even post-myocardial infarctions, there may be a decrease in the heart rate. Then you may have negative inotropic drugs, such as most antiarrhythmic drugs. You may even have excessive preload, like for example in mitral regurgitation, fluid overloads that may be due to NSAIDs, which cause fluid retention, which is why NSAIDs should generally be avoided in heart failure patients. And then fluid overload may actually cause left ventricular failure in a normal heart if the renal excretion is impaired, or if you give big volumes of fluid intravenously and they're running too fast. And more common if there is actually simultaneously a compromise of the cardiac function, and in the elderly, then you may get low output heart failure. And of course, chronic excessive afterload, like for example in conditions like aortic stenosis and hypertension. Then heart failure may be classified according to the duration. It may be acute heart failure or chronic heart failure. Acute heart failure is often exclusively to mean a new onset is of acute or decompensation of chronic failure. I will talk about what decompensation means just very soon. And of course, it's going to be characterized by pulmonary and or a peripheral edema with or without signs of hypoperfusion. Then chronic heart failure, it's going to be developing or progressing slowly. There's going to be venous congestion, which is much more common, but arterial pressure is well maintained, maybe until the very late stages. There are some precipitating factors. Just remember, heart fails. Number 1, hypertension, which is systemic. E for endocarditis, A for anemia, R for rheumatic heart disease and myocarditis, T for thyrotoxicosis and pregnancy, F for fevers or infections, A for arrhythmias, atrial fibrillation, complete heart block, even a sick sinus syndrome, I for infarction, myocardial infarction, L for lung infections, and of course the fails should have an E. E for embolism, pulmonary embolism, S for stress, which may be emotional, physical, environmental, dietary, or fluid excess. So, fun fact, heartbreak can actually cause heart failure. Okay? Believe it or not, heartbreak can actually cause heart failure. It's what is known as Takotsubo's cardiomyopathies. Please look it up. It's a very interesting thing to read about. Not interesting for the patient, of course, but interesting for you as a student to learn. And drop some comments in the comment section below to actually tell the viewers about what Takotsubo's cardiomyopathy is, if you actually know what it's about. So let's talk a little bit about the pathophysiology of heart failure. I know this is going to be a very long lecture, so please bear with me. If you are still watching this video, please continue watching this video till the end. I assure you that once you're done with this video, you will not have any confusion about heart failure anywhere, and you will be able to answer all your questions on your essays. You will be able to answer all your questions on your exams, even on the wards, and even when you're seeing patients, you will be able to see patients confidently and actually do the right thing. So let me show you a black screen. And of course, if you haven't yet subscribed, please subscribe to the channel. We need to reach 2,000 subscribers very soon. Okay, so here now I want to explain how blood pressure is really controlled. So remember that blood pressure has 2 mechanisms of which it is controlled. It has what is known as the short-term regulation of blood pressure and what is known as the long-term regulation of blood pressure. Short-term regulation of blood pressure is what is known as the baroreceptor arc. Long-term regulation of blood pressure is what is known as the Renin-Angiotensin aldosterone ADH axis. So I shall begin by the short-term regulation of the blood pressure. I think I did talk about this. I alluded to this when we were talking about hypertension. So I shall just remind you of those facts that we talked about. So remember that arising from the left ventricle, you have the aorta, which arises, ascends, and eventually it's going to be curving on that side. So you have the aorta here that's going to be arising, ascends, and it's going to be curving on the side. Now, remember that the aorta is going to be arising from the left ventricle, and then it's going to be going towards the right, or rather it's going to ascend from the right ventricle, left ventricle rather, ascend, and then it's going to curve. Here it curves at the point that is along the plane, what is known as the sternal angle, the junction between the manubrium of the sternum as well as the body of the sternum. You call that as the angle of Louis, or the sternal angle. So that plane, that's where you have the arcing of the aorta. So there are 3 main branches that arise from the aorta. So let's say this is coming to the right here. This is going to the left. Okay, so there are 3 main branches that are going to be arising from the aorta here. So the first branch, the second branch, and of course the third branch. So I really want you to actually keep this in mind, because once you actually understand this, it becomes very easy for you to actually understand the pathophysiology of heart failure, the drugs that we're going to be using when we're targeting heart failure, and the drugs that we're going to be using in other cardiovascular conditions, because this is very important for you to note. Okay, so here you have your right here you have your right side here you have your left side. So on the right side, okay, so on the right side of the heart here, you have what is known as your right brachiocephalic trunk, right brachiocephalic trunk, BCT. Now brachiocephalic meaning brachial coming to the hand, cephalic going to the head. So you have your right brachiocephalic trunk. So it means that this right brachiocephalic trunk is going to divide at a point. Whenever you see the word trunk in anatomy, know that it should divide at a certain point. So this is going to divide into a right internal carotid artery and then continue as your right subclavian artery. Okay, so you have this as your right subclavian over here. Then you have this as your right common carotid artery. Remember that common carotid, common also means that it's going to bifurcate at a certain point. So this will ascend and it will reach a place at the angle of the mandible where it bifurcates into two main arteries. It's going to be bifurcating into your internal carotid arteries, which is going to be supplying the structures within the cranial cavity, and the external carotid artery, which is supplying the structures outside the cranial cavity. So this is your internal carotid, this is your external carotid. Then the next branch here is going to be your left common carotid. Remember that the left common carotid is going to be arising directly from the aorta. So this is eventually also going to bifurcate at the angle of the mandible into an external carotid as well as an internal carotid. Then of course this one will be your left subclavian artery. Okay, so here you have your right subclavian artery. So I'm pretty much concerned at this bifurcation. At the angle of the mandible here, you have certain receptors that are present here. These receptors are known as mechanogated receptors. Okay, they are pressure sensors. They're going to be sensing the blood pressure. You can call them as carotid sinus receptors. Then you also have some receptors that are found here at the arc of the aorta, which are referred to as the aortic body receptors. Now they are pretty much nerves that are attached to these receptors. So attached to the aortic body, you have the vagus. Okay, so I shall put V, vagus. Okay, V-A-G, vagus. Remember that the word vagus comes from the word wanderer. So this is a nerve that wanders from the brainstem. It goes into the neck. It goes into the thoracic cavity. It even reaches into the abdomen. Then arising from the common carotid arteries here, you have your glossopharyngeal nerve. So you have your glossopharyngeal nerve here. Okay, glossopharyngeal GP. So these are taking information to the brainstem, because remember that the brainstem is what's going to be responsible for the control of blood pressure. There are some centers that are present in the brainstem. One of the important centers is what is known as the Vasomotor Center, which is present in the brainstem. You also have cardiac accelerator centers, which I shall say C+, and you have cardiac decelerator centers, C-. Okay, so this information is going towards the brainstem. It's going towards the medulla. Okay, the medullary oblongata. That's the one that's going to be responsible for the control of blood pressure. Then information that's supposed to be outputting from this comes out through sympathetic fibers. And remember that you have sympathetics going to be found at the heart muscle. So heart muscle, I shall put a heart here. You have sympathetic going to the SA node. Okay, the sinoatrial node. You have impulses going to the AV node, the AVN. Okay, so the heart muscle, the SA node, the AV node, and you also have blood vessels over here. Okay, blood vessels. So this is just the basic anatomy. I haven't yet started to talk about regulation of blood pressure. Now, between the carotid receptors and the aortic receptors, the carotid receptors are by far much more sensitive than the aortic receptors. Why do I mean this? The carotid receptors are able to sense both decreases and increases in blood pressure, while the aortic receptors can only sense increases in blood pressure. They can't sense decreases in blood pressure. So let me just say there is a decrease in blood pressure, because that's what's going to be happening in heart failure. So there's going to be a decrease in blood pressure, preferably below 60 millimeters of mercury, of a diastolic pressure below 60 millimeters of mercury. So if there is a decrease in blood pressure, it means that these carotid receptors are no longer going to be stimulated. Under normal circumstances, when these receptors are stimulated, there will be an increase in action potentials that are going to be carried in these nerves. Now remember that the vagus and the glossopharyngeal are parasympathetic nerves, so they are inhibitory nerves. So they're going to be pretty much inhibiting most of these centers that are found in the brainstem. So it means that now that you have inhibited these receptors, here, it means that it's going to be less inhibitory signals reaching the brainstem. So it means that the cardiac decelerator centers will be inhibited, whilst the cardiac accelerator centers will be stimulated. The vasomotor center will be stimulated. So predominantly, there's going to be a sympathetic outflow from the brainstem, a sympathetic outflow. So this is going to cause the heart rate to increase, the contractility to increase, the velocity of conduction of the impulse across the heart muscle to increase, and of course the blood vessels to constrict. Okay, so if the arteries constrict, it will mean that the total peripheral resistance increases. If the total peripheral resistance increases, it means that the heart has to contract much harder. If the veins constrict, it means that the venous return is going to increase, the end diastolic volume is going to increase, the preload is going to increase. Therefore, according to the Frank-Starling phenomenon, the contractility is going to increase. This is good for someone who has a blood pressure that is falling. And all these things are happening to control the blood pressure. This is a short-term regulation. I've only discussed half of it. If you actually want to get the full discussion so that I do not prolong this lecture, please check out this card right here on the video on hypertension. I think I explained this very, very well. So I will leave this discussion here with the baroreceptors. These are also known as baroreceptors. Okay. Then on the flip side, so let's talk about now the long-term regulation, because most of the pathogenesis of heart failure is going to be now based on the short-term and the long-term regulation. Now, if this person, before I actually erase this off, if this person has a falling blood pressure because their body is unable to meet the demands, the heart is unable to meet the body's demands, that means that blood is not really reaching the respective organs. So it means that the blood pressure is falling. Okay, so these mechanisms are meant to compensate. So within the early phases, there's going to be compensatory mechanisms to avert the heart failure. And of course, the person will compensate very well such that there will now be a balance and they won't actually have symptoms. So you refer to this as compensated heart failure. Okay, they won't have any symptoms. But now, whatever was good eventually can kill you. So these compensatory mechanisms, if the inciting agent that was causing the heart failure is not removed, then it may progress and lead to decompensation. So these compensatory effects that were initially good for the patient will now start harming the patient. What do I mean? If the heart is contracting harder, it needs more energy. If the heart is not getting more energy, and it means that it's going to predispose it to failing. If the afterload is increasing, it means that the heart has to generate a much greater force to overcome this resistance. So it needs more energy. So this can actually predispose it to failing because it has to now work harder. Same thing with the preload. If the preload is increasing, the heart muscles are being stretched out, then there's a lot of force that has to be generated so the heart can fail. So all these things are coming together and we are worsening the condition for the heart such that this person decompensates, and this is when now the symptoms begin to happen. So this can happen at initial presentation. So they will present to you acutely, or it can happen in a patient that has heart failure for a chronic time, and then all of a sudden they have an acute presentation. So they have acute decompensation in a chronic heart failure patient. Okay, so I hope that really makes sense. Then let's talk now about the renin-angiotensin-aldosterone axis, because that's very important. Let's get back to the blackboard. Okay, so remember that this is going to be initiated in the kidneys. So suppose this is a kidney here. So assume that this is a kidney. If you don't assume that it's a kidney, then that's your own fault. So the first thing that's going to happen is that there's going to be a decrease in perfusion of the kidneys. Now remember that when there is a decrease in the perfusion of the kidneys, this is going to be sensed by the juxtaglomerular apparatus, which has the Purkinje cells, the macula densa, and the elastic cells. So there's going to be there's going to be a decrease in perfusion of those cells. So these are going to be sensing this. There's going to be an increase in osmolarity. So these are going to be sensing this, such that now there's going to be a release of a compound that is known as renin. Okay. So there's a big argument between many clinicians on whether renin is a hormone or whether renin is an enzyme. So please comment below what you think renin is, if you think it's a hormone or if you think it's an enzyme. So this renin is going to now go and catalyze the conversion of a protein that is produced from the liver So there's a protein that is produced from the liver that is known as angiotensinogen. Now, whenever you hear the word ogen, it means it's a zymogen. It's a precursor enzyme. So the angiotensinogen is a precursor of angiotensin. So it's going to be converting angiotensinogen into angiotensin 1. So it's going to be converting it into angiotensin 1, AT1. Then angiotensin 1 is going to now flow, and in the lungs, you have an enzyme in the lungs that's known as the ACE, angiotensin converting enzymes. Remember that there are also ACE receptors. Sidebar, the coronavirus binds to the ACE receptors for it to actually gain into access into your pulmonary vasculature. And the ACE receptors are also found along blood vessels. They are also found along the lungs. They're also found across the GIT. So this ACE, or the angiotensin converting enzyme, is going to be converting angiotensin 1 into angiotensin 2, which is the active compound of this system. So now this angiotensin 2 brings about certain physiological effects that we're going to be seeing in these heart failure patients. So angiotensin 2, first of all, is going to cause blood vessel constriction. So it's going to be affecting the blood vessels. So remember, when the arteries constrict, then the afterload is increased. The heart has to contract much harder. The cardiac output is increased. It's good for someone who has a blood pressure that was falling. Then if the veins are constricted, then there's going to be increase in the venous return, increase in the preload. So it means that this is good for a person that had a blood pressure that was falling. Then in addition to this, the angiotensin 2 is going to stimulate the adrenals. Okay, remember that the adrenal gland is a small gland that is going to be sitting on top of the kidneys. So it's going to be stimulating the adrenal glands to produce a compound that is known as aldosterone. Okay, so there's going to be a compound that's known as aldosterone. Okay, aldosterone also has effects on the blood vessels. Okay, has effects on the blood vessels, similar effects to what angiotensin 2 has. So it also causes vasoconstriction. In addition to this, the aldosterone is going to be going back to the kidneys to cause reabsorption of sodium. Okay, and remember, wherever sodium goes, water is bound to follow. So once the sodium is reabsorbed, water is also going to be reabsorbed in the presence of ADH. Then this reabsorption of sodium as well as reabsorption of water increases the blood volume, and this increase in the blood volume is going to be increasing the stroke volume, is going to be increasing the cardiac output, is going to be increasing the blood pressure. Then in addition to this, ADH is also going to be released from the pituitary gland, PG. You're going to have ADH that's going to be released from the pituitary gland, and this ADH also has vasoconstrictory effects on the blood vessels. It also goes and stimulates reabsorption of water via the aquaporin 2 channels in the kidneys. So there's going to be reabsorption of water, the same discussion that I'm just from explaining. Again, I discussed this system in so much detail when I talked about hypertension, so please head to that video. I'll also leave a card at the end of the video so that you can check that out. And then with the aldosterone, I'm very, very particular with the aldosterone because the aldosterone can also go back and affect the heart. So it has been known that the longer that you have aldosterone in your system, then the heart undergoes certain changes. Because you're putting the heart muscle under stress, there are going to be certain changes that happen to the cells. So the first thing that's going to be there is that there's going to be hypertrophy of the cells. They're going to increase in size, and eventually there's going to be a dilatation. So they're going to now dilate, and the heart is going to dilate. So it means that they're going to lose their functionality. So this is actually what causes the heart to enlarge in size. The progression from hypertrophy to dilatation, and you call this as cardiac remodeling. So it's often due to aldosterone. So if you give drugs that block this system, they actually can improve the mortality rates of patients with heart failure. We'll talk about the drugs very soon. Okay, so you have this adrenal glands that are releasing aldosterone, the posterior pituitary gland, which is releasing ADH. Remember that ADH is also known as vasopressin. Vaso means blood vessel, pressin means to constrict blood vessels, so vasopressin. Then a sidebar note on the angiotensin converting enzyme is that, remember, it also breaks down bradykinins into inactive compounds. So keep that in mind, because one of the drugs, the ACE drugs, if you give them to inhibit the ACE, it means that the bradykinins will not be broken down. They begin to accumulate and they can cause a side effect of a dry cough, especially in patients that are taking ACE inhibitors. So I really hope this makes sense, because now these same mechanisms that are now compensating for the drop in blood pressure, for the drop in or the underperfusion of the kidneys, are going to be harming this individual. If you're retaining more water, increase in stroke volume, increase in end-diastolic volume, increase in the strain on the heart. If there's constriction of the blood vessels, constriction of the arteries, increase in total peripheral resistance, more work on the heart. Same thing with the veins. There's going to be increase in preload and much more work on the heart. So this predisposes the heart to actually failing. And then once the heart fails, then this is actually going to worsen. So now let's look at the pathophysiology of this in our words. So remember that heart failure can be classified as acute or chronic based on the time of the symptoms that develop. So the heart failure may be transient and reversible, or permanent and thus chronic. So when the heart fails, there are going to be considerable changes that occur to the heart and the peripheral vascular system in response to the hemodynamic changes that are going to be associated with heart failure. So remember that these physiological changes are pretty much going to be compensatory changes that are going to be maintaining the cardiac output as well as the peripheral perfusions. They are intrinsic mechanisms. Remember I talked about the Frank-Starling phenomenon? An increase in the venous return or the end-diastolic volume results in an increase in the stroke volume and the cardiac output within physiological limits. So this is a mechanism that's going to be matching the cardiac output to the venous return. Then of course is going to be myocardial hypertrophy that told you, the so-called cardiac remodeling, which is going to be initially beneficial because once the heart is hypertrophied, it's going to be pumping much harder, pushing out more blood, so the cardiac output will increase to some extent. But eventually there will be some ischemic changes, impaired diastolic filling, and eventually the geometry of the ventricle will change and it will begin to dilate. Of course, there are some extrinsic mechanisms such as the baroreceptor reflex, which is going to be the baroreceptor arc, the first thing that I explained, which is going to result in an increase in sympathetics. Remember that the sympathetics also that are increasing from this same baroreceptor arc can stimulate the release of renin. So once renin is released, it's going to stimulate the release of angiotensin as well as aldosterone eventually, and like I've already explained in the previous black screen. So here you have a decrease in cardiac output, so a decrease in the carotid sinus firing, an increase in sympathetic discharge. This is going to cause an increase in renin release. Remember, renin can also be released from a decrease in perfusion of the kidneys. And then, of course, the renin is going to increase the production of angiotensin 2. I've skipped so many steps here. Angiotensin 2 is also going to stimulate increase in sympathetic discharge. Remember that the sympathetic discharge is then going to be leading to increase in the force, the rate, the preload, the afterload. Angiotensin 2 is also going to increase the preload and the afterload. And of course, there's also going to be some remodeling that may be happening to the heart. The dilatation, the hypertrophy initially, and then eventually dilatation. Then remember that to compensate for the decrease in cardiac output, there's going to be activation of the sympathetic system and the renin-angiotensin system. So there are going to be features of adrenaline and noradrenaline that's going to be released to cause features like increase in heart rate, increase in contractility of the heart, and pronounced pronounced peripheral vasoconstriction. Sorry, I think I've been talking for way too long. Then remember that the renin-angiotensin aldosterone system is going to be activated by poor perfusion to the kidneys. Then, of course, the vascular tone is going to be increased by angiotensin 2. There's also another compound that's known as endothelin, which is a very potent vasoconstrictor. So the vasoconstriction is going to be increasing the afterload, and this is going to further reduce the ejection fraction and the cardiac output. Then stretching out of the heart chambers, there is another compound that is very, very important. So whenever now there is more blood in the atria, and stretching out of the atrial walls or stretching out of the ventricular wall, there's a compound that is released. In the atria, there's a compound that's known as atrionatriuretic peptide. In the ventricles is what is known as beta or brain natriuretic peptide. It's also been isolated from the brain of various other species. So these compounds are going to be preventing the reuptake of sodium. So they block the renin-angiotensin system. So we can actually use the beta natriuretic peptide, or the BNP, as actually a marker of heart failure and actually a marker of prognosis of heart failure. So just keep that in mind. So these peptides are going to be decreasing the blood volume and the blood pressure through sodium and water excretion. They are also going to be causing vasodilatation of the arterioles as well as of the venules. And unfortunately, in the long term, these compensatory mechanisms are going to be harming the heart and doing more harm than good. So the market constriction is going to be leading to an increase in the workload, increase in the afterload. So it means that the heart now has to work much harder to push blood into a smaller diameter vasculature than it was doing before. And then if the heart is also working harder, the heart rate increases. It means that the heart is also going to be working harder. And the increase in the workload means that the myocardium requires more oxygen, but remember that the coronary blood flow is depressed and it cannot really match this increase in oxygen. So it means that there's going to be a decrease in the cardiac output, and then progressively there's going to be a reduction in the sensitivity of the baroreceptor arc to the changes in pressure. And then eventually this reflex is very important in inhibiting the sympathetic activation, because remember, when the blood pressure increases, those receptors, the carotid receptors and the aortic body receptors, are going to be stimulated to inhibit the sympathetic output from the brainstem. And then of course, if this isn't really happening, there's going to be constant sympathetic stimulation, further increasing the workload on the heart. Then of course, this coupled with increase in ventricular filling pressure, which is caused by poor ventricular emptying, as well as the expansion of the intravascular volume, as well as the ventricular chamber wall is going to be subjected to stress. Then this can further tip this heart into beginning to remodel from hypertrophy to dilatation, then eventually heart failure. So because there is an increase in the mass of the heart, then there's going to be an increase in the demand for the oxygen, and then this is also not going to be met by the oxygen supply. Then of course you have this chronic activation of the sympathetic nervous system, the chronic activation of the renin-angiotensin-aldosterone system that may lead to cardiac tissue remodeling. It may lead to loss of myocytes, it may lead to hypertrophy, it may lead to fibrosis. Then of course this is also going to be prompting a vicious cycle. Then of course the severity of the clinical manifestations of heart failure have actually been described by the New York Heart Classification, which I shall talk about in the next slide. So let's just focus on this diagram here, this schematic here. You have sodium and water retention. Of course, this sodium and water retention is going to increase in the preload. So it means that increase in the cardiac work, so myocyte damage, so decrease in cardiac output. So this is going to further increase the renin-angiotensin system to reabsorb more water, and you can see the vicious cycle that you have created. On the other hand, the decrease in cardiac output is going to be increasing the sympathetic outflow. So this is going to cause a direct effect on the heart. So it's going to increase the heart rate. It's going to increase the contractility, further increasing the workload. It's also going to cause vasoconstriction that increases the afterload and to some extent also increases the preload. Then of course it's going to increase the cardiac work and then lead to myocardial site damage. Then of course there's going to be a decrease in cardiac output, and the vicious cycle continues. I really hope that helps you understand the pathophysiology of heart failure. I know this is a very, very long topic, but I'm trying to squeeze it into as effective as I possibly can. So here are some of the chemicals that are implicated. So you have in the pathways, you have an increase in the sympathetic activity. So the favorable effects in the initial stages is that there's going to increase in heart rate, increase in contractility, vasoconstriction. That's going to be leading to increased venous return and increased filling. This is a good thing that for someone who has a heart that's failing. But later on, the arterial constriction is going to increase the afterload. So it means that more oxygen is needed for the myocardium. Then of course, increase in the renin-angiotensin-aldosterone system will means that salt and water is going to be retained. So it's going to be increase in the venous return, increase in the blood volume. But of course, the renin-angiotensin system also leads to vasoconstriction that increases the afterload and also causes cardiac remodeling. Those are unfavorable effects that you do not want. You also have increased vasopressin, which retains salt and water, just like with the renin-angiotensin system. It also causes vasoconstriction, just like I have already explained. Then you also have increase in interleukins and tumor necrosis factors. Then these actually may have a role in hypertrophy. Remember, hypertrophy initially is a good thing because the heart is going to be contracting harder and increase in the cardiac output. But eventually, this can also lead to programmed cell death, which is known as apoptosis. And of course, endothelin is going to cause vasoconstriction to increase in the venous return, but the unfavorable effect is that it's going to cause an increase in the afterload or the total peripheral resistance. So these are just a comparison between the favorable effects as well as the unfavorable effects. So moving on to the New York Heart Classification. So this is a functional classification. that is used when you make a diagnosis of heart failure. This should be there in your diagnosis. So it has 4 classes. Class 1, there is pretty much no limitation. So the heart disease is present, but there is no limitation to physical activity. So there is normal physical exercise, and the person doesn't get features of fatigue, dyspnea, or even palpitations. And then class 2 is mild limitation of physical activity. So this person at rest, they will be comfortable, but when they have this normal physical activity, it may produce fatigue, it may produce shortness of breath, it may produce palpitation. Like for example, when walking a long distance or climbing 2 flights of stairs. Then class 3 is marked limitation of activity. So this person still will not have any symptoms at rest, but just gentle exertion or less than ordinary activities can actually cause symptoms. For example, just walking a short distance, the person is breathless, or just climbing 1 flight of stairs, the person is breathless. Then of course, class 4 is where they have symptoms at rest, and of course, they are going to be exacerbated by any physical activity. Talking about the clinical features, you have, if the person has features of congestive cardiac failure, remember I said congestive cardiac failure are features of congestion, especially pulmonary edema. So you may have shortness of breath, you may have fatigue, you may have signs of fluid retention, and most patients are going to be presenting with left-sided heart failure, which is a cause of right-sided heart failure. So they may start off with a left-sided heart failure that progresses to a right-sided heart failure, so it becomes a biventricular heart failure. Then, of course, heart failure can be compensated where the patient is stable and they are not really presenting to you with symptoms, or decompensated when the patient actually suddenly gets worse. So some symptoms include exertional dyspnea, orthopnea, which I already explained, paroxysmal nocturnal dyspnea, fatigue. Some signs include cardiomegaly, S3, S4 heart sounds, elevated JVP, tachycardia, hypotension, bibasal crepitations, pulmonary pleural effusions, peripheral edema, ascites, as well as tender hepatomegaly. So here's a table to put the left-sided heart symptoms, the right-sided heart failure symptoms, okay, signs and symptoms. Remember that the hallmark of left-sided heart failure are respiratory symptoms. So all these are respiratory symptoms, and then you may also have other symptoms. Then right-sided heart failure is going to be due to now congestion in the system. So you may have congestion in the liver that may lead to nausea, anorexia, early satiety because it's compressing on the stomach. You may also have right upper quadrant pain. You may have epistaxis. You may have which is nose bleeding. You may have nocturia. So on laying flat, the fluid backs up from the legs into the kidneys. There's a lot of filtration happening. Then there are some signs. Cachexia is just simply severe weight loss. Then cold peripheries, you may have what is known as pulsus alternans. This is its characteristic type of pulse, where you have a fluctuating amplitude from strong pulse followed by a weak pulse. Strong pulse, weak pulse. And you may have a displaced apex beat laterally. Remember that the apex beat is going to be found in the left side of the body, mid-clavicular line, 5th intercostal space, okay, or 6 in some cases, but rather 5th intercostal space rather. If it's in the 6th, it's displaced. Then you may have crepitations, which are also known as rales. Crepitations just simply are these abnormal lung sounds that you hear at the base of the lungs, especially in patients with heart failure. It sounds like someone who's walking on leaves. So after this, I just want you to Google crepitations or just search crepitations. I'm sure there will be a video on that. Someone would have already uploaded a video on that on their YouTube channels or wherever it may be. You may also hear an S3 heart sound. Do the same thing with the S3 heart sound. I can't really explain this. I will have a separate lecture on heart sounds. Then also have you may also have an S4 heart sound, which is very common in diastolic heart failure. And then in right-sided heart failure, you may have an increase in JVP, peripheral edema, ascites, hepatomegaly, and of course a right ventricular heave, which is due to a pulmonary hypertension. So if you place your arm across the sternum, then you feel as if your arm is being lifted off the chest. So you call that as a heave. Then to make a diagnosis of heart failure, there's what is known as the Framingham Criteria. This is now going to be the difference between you getting an A+ and you getting an A. So the Framingham Criteria just uses major and minor criteria. So the major criteria include things like paroxysmal nocturnal dyspnea, orthopnea, elevated JVP, pulmonary rales or crepitations. Crepitations, also known as rales. You can also call them as crackles. S3 heart sound, a cardiomegaly on chest x-ray, which is manifested as an increase in cardiothoracic ratio greater than 50%. acute pulmonary edema, hepatojugular reflux, neck vein distension, increase in central venous pressure that is greater than 15 centimeters, and then of course weight loss that's greater than 4.5 kg in 5 days in response to treatment. Then the minor criteria include presence of peripheral edema, bilateral ankle edema, nighttime cough, dyspnea on exertion, pleural effusions, a heart rate that's greater than 120, hepatomegaly, a decrease in the vital capacity by 1/3 from the maximum recorded. And for you to make a diagnosis of heart failure, you can either get 2 major symptoms or 1 major and 2 minors. Then the minor criteria are only acceptable if they cannot be attributed to any other medical cause but the heart failure. So they shouldn't be due to pulmonary hypertension. They shouldn't be due to chronic lung disease. They shouldn't be due to cirrhosis. They shouldn't be due to ascites. They shouldn't be due to nephrotic syndrome, because these things can also cause, a nephrotic syndrome can also cause edema. Then of course, this Framingham criteria has 100% sensitivity and 78% specificity in actually identifying patients with congestive heart failure. When it comes to the diagnosis of the condition, you may order some investigations, but first of all, take your history and clinical examination. There are some important questions that you should ask this patient on the history, and you should perform a full cardiovascular examination. Then blood investigations include an FBC with a differential count, because anemia can mimic and exacerbate heart failure. Urea, electrolytes, creatinine, and liver function tests. You want to check the functioning of the liver and the kidneys, because heart failure can affect these organs. And also, you want to rule out any other cause of fluid retention. Then order for cardiac enzymes, because heart failure may be due to a myocardial infarction. Then of course, investigate cardiac risk factors. You want to do a lipid profile where you check for your cholesterol levels, your triglyceride levels, your LDLs, your low density lipoproteins, your high density lipoproteins. You also want to check for your blood glucose level. Then of course, you may do a thyroid function test if you are suspecting high output failure due to thyroid toxicosis. Then even hypothyroidism can also present you with features of fatigue and edema, so you want to rule that out. You may also do a beta type of natriuretic peptide. Like I already told you, it may be useful in prognosis of heart failure. Then imaging, you order for a chest x-ray. So there are 3 imaging that you should always order for in patients with cardiovascular conditions. Order for a chest x-ray, order for an echocardiograph, order for an electrocardiograph. So a chest x-ray, an echo, and an ECG. So on your chest x-ray, you may see prominent pulmonary vessels. That's dilatation of the pulmonary vessels and interstitial edema. You may also see diffuse interstitial or alveolar shadowing. You may see vascular redistribution, or what is known as cephalization. I'll show you what these things look like on the image in the next slide. You may see perihilar bat wings pattern. You may see cardiomegaly, which is an enlarged cardiac silhouette, increase in cardiothoracic ratio. You may see pulmonary congestion, so upper lobe deviations, or diversions rather, fluids in the fissures, curly B lines. You may see pleural effusions. You may also see peribronchial coughing. So here's an image. So this is cephalization. The blood vessels going to the apices of the lungs are dilated, while the ones going to the bases are not so dilated. You see this cephalization that is happening here. You have this cephalization. Then you see these pleural effusion within the fissures. So this is the horizontal fissure. You can see that there's a pleural effusion there. Increase in the cardiothoracic ratio. Remember that the maximum diameter of the heart should be less than 50% of the maximum diameter of the thorax. Then, of course, you also have these curly B lines, which are these small lines, 1 to 2 centimeters. They are thin, extending from the periphery of the lungs. Then they are usually a feature of interstitial edema. Then you may see what is known as a bat wings pattern, where you see an increase in opacity at the hilum, and it looks like the wings of a bat. Some people call them angel wings. When you do an echocardiograph, it's usually diagnostic. So you're going to be looking at the wall thickness of the ventricles. You're going to be looking at the dimensions of the ventricular cavities. You're also going to be looking at the functioning of the ventricle, where you look, if it's less than 40% ejection fraction, then this is a systolic failure. If it's greater than 50%, then this is obviously a diastolic failure. Then, of course, the electrocardiograph, you may order for an electrocardiograph, which may be abnormal in 80% of the patients. So it is rare to actually get a completely normal ECG in a chronic heart disease patient. So there are some non-specific changes, like changes that may point you towards a myocardial infarction or atrial fibrillation. You may get some axis deviation, which is less common. Then you may get features of left ventricular failure. So this is how you denote this on your ECG. So remember that you're going to have an S wave you have a QRS complex. The Q wave is a negative deflection, the R wave is a positive deflection, and the S wave is a negative deflection. So the S wave in lead V1 added to the height of the S wave in V1 plus the height of the R wave in V5 or V6 should be at least 7 squares. If it's more than 7 squares, then there's most likely left ventricular failure. Then of course you may get some features of left ventricular strain pattern where you get ST segment depression and T wave invasion, especially in V5 and V6. If you have no idea what this is, please review the ECG series. There is a playlist on my channel about ECG and learning how to read the ECG. Then less commonly, you may see a mirror image of ST segment elevation in V1 and V3. Then with right ventricular failure, you may get this tau R waves in V1. So how do you know? They should be more than 7 squares, and the R wave is greater than the S wave in lead V1. And of course, you may get these large S waves in leads V4 to V6. You may get a right ventricular strain pattern, which is ST segment depression and T wave invasion in lead V1 to V3. So moving on now to the last segment of this lecture. I know it has been a very, very long lecture, but I hope it has really helped you. So management. So if you're in 5th year, I think you can be escaped, or you can actually escape at this point. If you're in 7th year or if you are an intern, then this is where the meat of the discussion is. I presume you already know whatever we've talked about up to this point. So principles of management. So the first thing is you want to identify and treat any precipitating factors. The second thing, you want to control the congestive state. The third thing is you want to improve the myocardial performance. The fourth thing is you want to prevent any further deteriorations of the myocardial function. So you want to slow the progression of the heart failure. And then of course, treat any underlying cause. It's not all patients that have heart failure that we actually admit. We only admit those patients that have severe decompensated heart failure, those that have worsening renal function, those that have altered mental state, those that have dyspnea at rest, those that have significant hypoxemia, those that are hemodynamically unstable and they have significant arrhythmias, those that have acute coronary syndromes, and those that have electrolyte imbalances. This is just some of the few indications. There may be some other indications. This is not an exhaustive list. So general measures that we do. We counsel the patient on diet restriction. So they should reduce their salt intake to less than 2 grams per day. They should reduce their fluid intake to moderate. So they should get help if they notice that there's a rapid gain in their weight. So more than 2 kgs in 3 days is a very big, it should be an alarm. They should have daily weighing. So you should be weighing your patients on the ward. Then of course, encourage for weight loss in obese patients. But this should be counseled to the patient that they should exercise within their limits. Not beyond the limits, but within their limits. If they drink alcohol, tell them to stop taking alcohol. If they smoke, tell them to stop smoking. Tell them to avoid exacerbating factors such as certain drugs like NSAIDs that may cause fluid retention, drugs like verapamil that may actually slow the heart rate. Then oxygen administration can be given if needed. Exercise is also done for patients with class 1 or class 2 type of heart failure, and the oxygenation is actually indicated for patients that have an oxygen saturation that's less than 95%. If you have any comorbidities such as ischemic heart disease, treat the ischemic heart disease. If you have any comorbidities such as atrial fibrillation, dyslipidemias, treat those things. Then pharmacological management. The first thing that we had talked about on the principles of management is controlling the congestive state. So you want to get rid of that excess fluid. So how best can we get rid of that excess fluid? Diuretics. So you can give diuretics which are used to relieve the congestion. Remember that the diuretics are going to be getting rid of the fluid that is in the vascular space. They won't be getting rid of the fluid that is outside the vascular space. It's often a trick that examiners like to ask you. How is the diuretic going to be working? Which fluid is going to be gotten rid of? It's the one that's in the blood vessel, such that now you create a vacuum and the fluid that is trapped in the peripheries is drawn into the vascular space. So you use this to relieve congestion, you use this to reduce or prevent edema. And most patients with heart failure have some degree of symptomatic congestion, and they may benefit from diuretic therapy. Loop diuretics are very important. Thiazide diuretics are also very important, especially in patients that have refractory heart failure. So one drug that we commonly use is furosemide. You may know it as Lasix. So furosemide, you may start with an initial dose of 20 to 40 milligrams orally once a day or twice a day, or even 20 milligrams IV. Maximum dose that you should give per day is 400 milligrams or 80 milligrams if you're giving it IV per day. Okay, so increase the dose as necessary. You may have some side effects such as hypokalemia, so monitor your electrolytes, renal impairment, and you also want to add potassium, a potassium-sparing diuretic such as spironolactone if the potassium concentration is less than 3.2. Because remember that these diuretics are going to be losing potassium in the urine. Then, of course, if this patient is also taking digoxin, also give potassium, because how digoxin works, hypokalemia can actually exacerbate the side effects of digoxin. Then, if they have refractory edema that's not responding to just the furosemide, we can add a thiazide diuretic. So we can add a hydrochlorothiazide, initial dose of 25 milligrams orally per day, and a maximum dose of 100 milligrams in a day. Then this is very, very useful in controlling or giving the patient symptomatic relief, but it doesn't improve any survival of the patient. You may also add a certain drug which is known as spironolactone. Now remember that spironolactone is often just given to patients that have advanced heart failure. So I would just say give it to patients that are at class 4. So those that have symptoms even at rest. So this is going to be an aldosterone inhibitor. So it inhibits the functioning of aldosterone. So initially you can give a dose of 25 milligrams per day or every other day. Then you can go to a maximum of 50 milligrams orally twice a day or even higher, slightly higher. Side effects of this is that it causes hyperkalemia. So you should monitor the potassium levels. Remember that potassium is one of the electrolytes that shouldn't be allowed to actually sway because it may lead to the heart actually stopping. Okay. So as a result, the drug should be used in patients that have a creatinine level that's above 2.5 milligrams per deciliter. Then one of the side effects that spironolactone can cause is gynecomastia, especially in men. Then of course, spironolactone 25 milligrams per day orally actually decreases the mortality by about 30% when you add it to the conventional therapy. Then moving on to the other principle, enhancement of the myocardial contractility. So here you're going to be causing the heart to contract harder. So remember that digoxin is one of the important drugs here. So digoxin is a drug that actually helps the symptoms, even though in those patients that have sinus rhythm, and it should be considered in patients that have left ventricular systolic dysfunction and those that have signs and symptoms of heart failure, whilst they're receiving therapy with drugs like AC inhibitors, beta blockers, or in patients with atrial fibrillation. Now remember how digoxin works. Digoxin is going to be working to inhibit the sodium-potassium ATPase pump such that there is intracellular accumulation of sodium, intracellular accumulation of calcium. Ergo, there's going to be contraction of the myocardium to increase the contractility. That's one way in which it works. The second way is that it also works as a neurohumoral modulator, where it actually mediates to increase the parasympathetic outflow, such that this parasympathetic outflow is going to be blocking the AV node. It's also going to be slowing down the AV conduction, such that if there's an arrhythmia, it can also be used as an antiarrhythmic. So initial dose, this is a drug that has a very, very narrow therapeutic index, meaning that just slight changes in the dosage can cause maximum side effects. So the dosage, initially you should give 0.125 milligrams once a day, or you can give a maximum of 0.25 milligrams per day orally. Okay, so if you're in sinus rhythm, you give 0.125 milligrams. Then digoxin is obviously going to be improving the symptoms. It's going to be reducing the duration and the need of hospitalizations in patients with heart failure. But long-term survival, there is no benefit. There's no increase. Now, digoxin is recommended for patients that have left ventricular systolic dysfunction, particularly patients that have atrial fibrillation. Okay, it's contraindicated for patients that have cardiac outflow obstruction in, for example, mitral stenosis in the absence of atrial fibrillation. Cor pulmonale, which is right-sided heart failure caused by pulmonary pathology. It's contraindicated. And because of the narrow therapeutic index, like I already mentioned to you earlier on, there are some side effects that you should watch out for. Side effects of digoxin toxicity include anorexia, vomiting, weight loss, but an important one is yellowing of the vision, xanthopsia. Okay, you may also have delirium, you may have neuralgias, you may have gynecomastia, arrhythmias of different types. And whenever you see this, please stop the digoxin, give the digoxin binding antibodies. That's your antidote. Then when there's electrolyte imbalance that is suspected, digoxin should be withheld. And of course, the patient should be observed for a few days before reinitiating with a lower dose. And of course, one should also be given with potassium chloride. Remember that digoxin and potassium compete for the same binding site. So if you have hypokalemia, it means that the effects of digoxin will be much higher. If you have hyperkalemia, then the effects of digoxin will be much less. Then you may also give vasodilators, which improve the contractility of the heart. First line is our ACE inhibitors, but you must ensure that there is renal function. So enalapril has actually the most evidence and should be offered to all patients. So those that do not actually tolerate enalapril can actually be given angiotensin receptor blockers. You may also give other vasodilators such as isosorbide dinitrate, 10 milligrams orally 4 times a day, or you can actually reach a maximum of 80 milligrams orally 3 times a day. Hydralazine is rarely used, so I will not even talk about it because we usually reserve it for patients that we treat hypertensive emergencies with. I will not go into details of that. Then you want to also prevent deterioration of myocardial function, which is often using the ACE inhibitors, enalapril. Okay, that's the one I want you to know, enalapril. So enalapril is given at 2.5 milligrams orally twice a day with a maximum of 10 to 20 milligrams orally twice a day. Side effects include angioedema, acute renal failure in patients with bilateral renal stenosis. It is contraindicated in patients that have a creatinine greater than 3 milligrams per deciliter. And of course, there may also be a cough. Contraindications include angioedema or anuric renal failure, pregnancy, hypotension, a creatinine that's greater than 2 milligrams per deciliter, that's roughly 265 millimoles per liter. And the two side effects are serious and they actually necessitate for you to stop taking the drug. So know these dosages because you will be using these drugs. Then, of course, for patients that react to enalapril, you can give angiotensin 2 receptor blockers such as losartan, 25 to 50 milligrams, orally once a day or twice a day. Beta blockers can actually be used as chronic therapy in patients with non-valvular congestive heart failure. That's not acute. In patients who have decompensated heart failure, it reduces mortality. So initially, beta blockers were never given in patients with heart failure, but what we've realized is that beta blockers actually relax the heart and actually reduce the workload on the heart. So it makes it much better for a patient who has a heart that's failing. So they shouldn't be given in patients with an unstable heart failure. It shouldn't be given in patients with hypotensive states because you worsen this. It shouldn't be given in patients with severe fluid overload, in patients with sinus bradycardia, in patients with asthma, in patients with AV blockage. You shouldn't give this. Carvedilol is the best, which can be given initially at 3.125 milligrams orally twice a day up to 25 to 50 milligrams orally twice a day. Wait for at least about 2 weeks before you actually increase the dose. You can also give metoprolol 6.25 milligrams orally twice a day with a maximum dose of 75 milligrams orally twice a day. Then, of course, with right ventricular failure and heart failure with preserved ejection fraction, there's very little evidence-based treatment to this type of heart failure. So except we just give symptomatic relief with the diuretics that we talked about. We manage the comorbidities, and of course some lifestyle changes. Then long-term oxygen therapy can actually benefit patients with cor pulmonale. And remember that the drugs that you should avoid in heart failure patients, avoid NSAIDs. So avoid diclofenac because it may cause fluid retention. Low-dose aspirin can be given. Avoid steroids. Avoid calcium channel blockers, especially the rate-limiting ones, verapamil and diltiazem. Avoid pioglitazone. Avoid the tricyclic antidepressants. Avoid beta agonists. They may exacerbate heart failure. So here are the guidelines of the different classes. Please, you may pause the video here at this point. You may get a screen grab of this. This is very important for you to know. and it may help you during your practice. It may help you when you're dealing with heart failure patients in the different classes, the different drugs that are actually given. Then in patients with intractable heart failure, where you have actually done everything right and the patient still is in heart failure, you should actually reassess the cause of the heart failure. You should ask yourself, are the patient actually taking the drugs? Have you reached the maximum doses of the drugs? If you're on furosemide, switch to a different drug, bumetanide. So 1 5 milligram tablet is equals to 200 milligrams furosemide. So this might help. So for these patients, you admit them for strict bed rest. You may have sodium and fluid restrictions, so less than 1.5 liters in 24 hours orally. You can also add metalazone, which is a diuretic, as well as IV furosemide. You should also give opiates, IV nitrates to relieve symptoms. You daily weigh this patient, frequently check their labs, urea and electrolytes. You give them a DVT prophylaxis, so heparin and anti-embolism stockings. And then, of course, in extreme cases, you may actually try IV inotropes. It may be difficult to actually wean the patient off this when you try this, so this should be your last resort. And of course, consider cardiac resynchronization as well as left ventricular assisted devices, even a heart transplant in cases where you've tried everything and everything else has failed. I really hope you have understood about heart failure and its management, its pathophysiology, the different types, and the different causes. Thank you for taking your time to listen to this very, very long video on heart failure. It is indeed Cardiac Week on the channel, so tell a friend to tell a friend. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. To Zambia and beyond, my name is Dr. Moses.